I think just leave your screen on in case you have problems again putting it on. It doesn't matter if you're...
So
let's keep it on this slide, so we'll just get started from there itself.
Okay.
So we are live in 3, 2, 1. So good evening and welcome to this Oref India web class for orthopedic postgraduates on Ortho TV. And for further proceedings, I'll hand it over to convener Dr. Janki. Over to you, Janki. John, sir, are you going to start?
Yeah, okay. It doesn't matter. And either of us can start. That's not a problem. So good evening, everybody. Welcome to today's webinar. And we have the pleasure of having a very eminent speaker today, Professor Shantaram Shetty from Mangalore. I think he doesn't need any introduction to orthopedic surgeons. He is well known for his work both in clinically and in the scientific field in terms of academic and research work that he's done over the years. And he still has this almost passionate enthusiasm to teach. So it's a great pleasure to have Professor Shantaram Shetty with us today, and he's going to talk to us about stem cells in orthopedics and trauma. So over to you, Dr. Shantaram.
Thank you. Thank you, John. It is always a pleasure to be associated with you. And I know for the last so many years, you have been running this course all around the country, and we are a part of it. We even conducted one of the courses in Mangalore. Because of the pandemic, we will have to stick on to this virtual media. Anyway, it is a pleasure to share a few of my thoughts on stem cells in orthopedics and trauma. And thank you for the opportunity, and congratulations for all the good work you're doing and you and your team are doing, John. All the best, and may God bless you. I greet you from my university and from my own hospital. And talking of stem cells, what is stem cell? Is it a giant cell? Is it a pleomorphic cell? Is it a modified white cell? Is it or is it a primitive cell which can self-renew itself? Or is it a cell which mutates by itself? I asked this question and in an open class where all the postgraduates and even our staff members were there. And though few of them answered, it is a primitive cell which can self-renew itself is a stem cells. When I asked this question to my own university, in the university class, 75% unfortunately of the undergraduates, 40% of the postgraduates as late as 2021, and 30% of the staff had no definitive answer or knowledge of the stem cells, which is perhaps the most contemporary research going on in the world today. And 3 of the last 7 Nobel Prize laureates in medicine were related to stem cell research. And of all these 8 people, the most notable is perhaps our own orthopedic surgeon. The Nobel Prize in Physiology or Medicine in 2012 was awarded jointly to Sir John Gordon and Shinya Yamanaka, who is an orthopedic surgeon from Japan, for the discovery that mature cells can be reprogrammed to become pluripotent. This was a remarkable achievement because now the mature cells can be programmed to become pluripotent cells. Stem cell, I'll just mention as to what is a stem cell and the importance of the stem cell related to orthopedics and trauma in just about 27 minutes. Well, stem cells are primitive cells that can renew itself and differentiate into more than 200 types of body cells and regenerate deteriorating cells in different parts of the body, such as it may be the heart, the bones, the muscles, and nervous system, etc. It is now well known that stem cells in various forms can be obtained from the embryo, from the fetus, and as I told you, in the adult. So self-renewal cells differentiate itself to specialized cells, to muscle cells, and a nerve cell. Gentlemen, stem cell is the very origin of life. All cells come from this primitive cell, the ultimate stem cell. Self-renewing cells with the potential to differentiate are termed as stem cells. and are an essential part of normal growth and development of body. These unique properties make stem cells very promising for supplying cells to treat debilitating diseases, like Alzheimer's, cancer, different types of cancers, Parkinson's, type 1 diabetes, stroke, burns, heart disease, and as far as orthopedics is concerned, it is in osteoarthritis, in rheumatoid arthritis, even in non-union of bone, in cartilage defects, and perhaps ultimate will be spinal cord injuries. Currently, donated organs and tissues are often used to replace those that are diseased or destroyed. Unfortunately, the number of people needing transplant far exceeds the number of organs which are available. That's why stem cells offer the potential tomorrow for supplying cells and tissues which can be used to treat these various diseases which I mentioned. Well, stem cell hierarchy, either it can be totipotent, it can be pluripotent, it can be multipotent. Totipotent is, as you know, the hierarchy as such, the zygote to the morula to the blastocyst, and the PGC to ectoderm, mesoderm, and endoderm. And finally, what cell you want to develop into an organ. Sorry. So as I told you, these sources of stem cells can be embryonic, that is cells from the human blastocyst, which I showed you at the cross section. It can be the fetal stem cells, cells from the aborted fetuses, or more commonly, which in many of the places we use the umbilical cord stem cells, cells from the umbilical cord blood of the newborns, or it can be placenta-derived stem cells, the cells from the placenta, or it can be adult stem cells, as I told you, cells from the adult tissues as such. Types of the stem cells and their potency, as I told you, the totipotent, the multipotent, pluripotent, and the multipotent. The totipotent stem cells are embryonic stem cells. They are capable of generating all cells of the body and cells needed for complete embryo development. It can develop into a complete embryo. Totipotent stem cells are found only in the early embryos. That has to be taken. Each cell can form a complete organism. Whereas pluripotent stem cells exist in the undifferentiated linear cell mass of blastocyst and can form any of the over 200 different types of cells found in the body, and describe the stem cell that can give rise to cells from all these three embryonic germ layers, mainly the mesoderm, the endoderm, and the ectoderm. Types of stem cells and their potential to contain the multipotent is much more important, can generate cells within the same tissue and embryonic layer. So this is the difference between totipotent, pluripotent, and the multipotent stem cells. So it can be from the embryonic, from the fetus, from the adult, from the blastocyst. Coming to the plasticity of the adult stem cells, which are multipotent, as you see in the slide, adult stem cells, the plastic changes, it metamorphoses into a transdifferentiation, and it can change itself into any tissue as a neuron, the erythrocyte, endothelial cells, and myocyte, chondrocytes, and whatever tissue you want to. So what is about mononucleated seed? This is the difference between from the bone marrow aspiration as such, from the bone marrow, or from the adipose, or from the peripheral bloods, placenta and the umbilical cord blood, mononucleated cells, and then they convert itself into multipotent cells, into adipocytes, the chondrocytes, and osteocytes, and even myotubes, which can be expandable, it can be autologous, can be genetically modified, and it can be immunoprivileged. So the potential uses of this, as you see, it can be used in basic research. It can be used in gene therapy. The stem cell can be used in cancer research. So identifying the drug targets, it can be cultured, pluripotent stem cells can be used, and it can be used for bone marrow for leukemia and chemotherapy. The nerve cells for Parkinson's, as I told you, heart cells for even heart disease, and pancreatic islet cells for diabetes, especially type 1 type of diabetes. So what are they? See, these are the different scopes which you see as you see there. It can be the potential clinical uses of stem cells can be in stroke, in baldness, in blindness, in wound healing, and bone marrow transplantation currently is established, and even in osteoarthritis, and even in multiple site cancers, and even a lot of research is being undertaken in muscular dystrophy. Orthopedic applications of stem cells, coming to apart from the different applications which I mentioned, we orthopedic surgeons are mainly looking to these critical areas of critical bone defects, especially non-union of bones, avascular necrosis, which still remains a challenge for orthopedic surgeons, cartilage repair, where there is loss of cartilage, and it is again a problem for whether it is trauma or osteoarthrosis or any cartilage defect. Ligament and tendon repair, a lot of research is being undertaken in this particular field. And further research is being undertaken. Still, we haven't conquered spinal cord regeneration, and though false claims are made, it is still not yet conquered, but we are likely to conquer this in the years to come. Intervertebral disc degeneration and even muscular dystrophies. Bone marrow injections recently have evoked a lot of interest around the world. And in our own institution, with the collaboration from Christchurch University and the Christian University, Korea, we have done some cases, especially in delayed and non-union, and the results are quite encouraging. What we should understand is the aspirated bone marrow will have cellular components of blood, including RBCs, WBCs, platelets, plasma, and even stem cells, with limited number present per area. This has to be taken into consideration. So it is observed that in the nucleated cells from the bone marrow aspirate are multipotent stem cells. Moreover, the presence of RBCs, WBCs, and plasmas will retard the activity of stem cells. This point has to be taken into consideration. If it is a whole blood which is taken as in PRP, the concentration of stem cells will be much less. Hence, the aspirate is centrifuged and the stem cells, the ratio is brought down. The method of aspiration and the needle use and the density gradient configuration, the stem cell population from RBCs and plasma cell is fairly well standardized now, after it was initially reported by Kim et al. Way back in 2012. It is also important that the stem cells injected into the site requires scaffolding for the cells to remain in place and potentially differentiate into cells with osteoplastic activity. So these 2 points will have to be taken into consideration, especially the gradient centrifugation and also the use of a scaffolding media for the cells to remain in its particular place so that it won't be dispersed. Here is a classical review article and systemic review of clinical applications and complications of bone marrow aspirate concentrate in the management of bone defects and non-union. You would go through this article, it gives a review article which gives all the details of the requirement for a BMRC. We established our own research lab, which is a tailor-made research lab, which was installed by the South Koreans. And this is the lab which you see, which has to be foolproof in every way. And we have MOU with these different universities, and we are carrying on this research. Hopefully, we will reach a definitive end after some time. Apart from the research undertaken, we have worked on the clinical applications of cells and stem cells in orthopedics and trauma. And this presentation deals with what was done and the results of cell and stem cell-based therapy through bone marrow aspirate concentrate. You will have to differentiate between a PRP and a bone marrow aspirate concentrate, and especially in delayed and non-union of long bones. What is important is to centrifuge the bone marrow aspirate. You separate and collect the separation and collection of PRP and the puffy core. See, you see the central, which is the puffy core, and bone marrow aspiration, which is the collection tube, which is with the balancer, and it is separated as a plasma, and mix the BMAC with centrifugal and fibrin using 2 or 3 way connector. And step 2 is to inject the mixture of BMAC and centrifugal surgical fibrin to the damaged site of bone or cartilage, as you see here. What is important is the puffy layer, which is in between, whereas where the lower layer is the RBCs and the above is the plasma. Buffy coat based PRP of whole venous blood is a concentrate of natural reservoir of many growth factors, which has to be taken into consideration. And it is important for tissue healing. And leukocytes rich in inflammatory molecules, and it lacks mesenchymal stem cells. Both play an important role in wound healing, bone repair, and soft tissue regeneration. PRP is prepared by centrifugation of whole venous blood. The concentration of platelets, and residual leukocyte content may vary due to the age sometimes, sex, and general health status of the patient, and in part to the preparation method. So platelets, we should understand, are natural resources for growth factors, especially important for tissue healing. Platelets are rich source of more than 20 different growth factors and cytokines. Physiological or artificial activation of plate cells release growth factors, which display chemotactic as well as direct or indirect regenerative effect. Thereby, the classical examples of platelet-derived growth factors, the PDGF or the TGF-B, the transforming growth factor, or the FGF, the fibroblast growth factor, or the list is almost many, the epithelial growth factor, the insulin-like growth factor, the platelet-derived angiogenesis growth factor, which is important, and finally the vascular endothelial growth factors, the VEGF. They play a very important role in enhancing one or more of the phases of ontogenesis to bring about healing. So in short, the PDGF, which I mentioned, PDGF and FGF especially stimulate the proliferation of osteoblastic progenitors, and the TGF increases the matrix synthesis, whereas VEGF and FGF enhances early angiogenesis and revascularization. All these are important, these growth factors are important, and in bringing about union or whatever modification you want in the bone. Bone marrow aspiration is a concentrate of PRP. We must understand the difference between plain PRP, where higher counts of immature red blood cells and mesenchymal cells. The concentration of stem cells per BMC varies from 0.02 to 5.4 into 10 based on the cell surface markers expression profile. This surface marker expression profile is important to understand it. Whereas I told you already, the original PRP contains only 0.001% of the stem cells. BMC is typically prepared by centrifugation, as I told you. The concentration of platelets and residual leukocyte content may vary due to the age and sex, as I told you. Whereas for cartilage regeneration, it's a different ballgame. The same 2 syringes are used, but fix the above syringes 1 to 2 to deoject syringe, and ready to inject thrombin stimulates both the proliferation and migration of primary osteogenic bone marrow stromal cells, osteoprogenitus, during the bone wound healing. Morphology, proliferation, and osteogenic differentiation of HMSC in fibrin gels dependent on the fibrinogen concentration thrombin ratio, which is important, so that for cartilage transfer, it is important. And also here, hyaluronic acid suppresses the breakdown of tissues by inhibiting the inflammatory cytokines and by activating the metalloproteinase inhibitors. We in our own lab bone marrow aspiration, we did a study and of the iliac bone grafts with the Ria-Reamer aspirator, and isolated mesenchymal stem cells are being analyzed for their cellular and biological properties, including markers, expression, and differentiation into osteocytes and adipocytes. Other orthopedic applications of Surgifill, which is it can be a bone void filler, the bone graft supplement can be used, or cartilage defects which have to be taken into consideration. I told you about the Surgifill which is used, which is a triple helix structure of atelocollagen. Optimal cellular scaffold it gives, increasing the cellular migration and conduction, providing enriched sites of adherent cells, optimizing structural stability to maintain scaffold integrity, and the newly made tissues properly substitute atelocollagen. It is the atelocollagen which is used, and ideal biocompatibles, others, there is no risk of BSE, bovine sponge form encephalopathy, no skin test required, and no antigenicity, and no immune reaction is there. Atelocollagen used to be, it can be even a short question in the examination for the postgraduate especially, is the pepsin stabilized, the solubilized type 1 collagen solution. It's a collagen solution and it's a native collagen, acid solubilized type 1 collagen, and atelocollagen is a water soluble form of collagen. It can be engineered into any shape, which can be twisted, it can be turned, it can be as the shape which you want, so that there will be adherence of the cells. It's a major animal protein that is used as a highly biocompatible biomaterial in regenerative medicine today, and cell culture, cosmetics, even cosmetic surgeons use this, and in drug delivery technology. As you see the collagen molecule being twisted, and you would see it can be brought into any shapes. Here is a video clip so that the time won't be wasted. I have put it into, instead of 15 minutes. These are the steps how you really collect the bone marrow. That's the iliac crest which you see there. You pinpoint, and the bone marrow is centrifuged in a centrifuge for 5 minutes with a 3,200 revolution per minute. And that is the balancer, which is the container, as I told you. And at the end of centrifuge, after centrifuge with the buffet, that are the three layers which you can very clearly see. The superficial layer, the middle, the buffet layer, and the dark layer of RBCs below. And this is in a double syringe. It is taken from the buffet layer of the container, and it is mixed with Surgifill collagen, atelocollagen, and then it is injected directly into the fracture site, the non-union sites. And that is the non-union site. And before you inject, you take a whiteboard needle and see that the ends of the non-union sites are really pricked many times, so that the revascularization can take place, and then you inject that depending on the non-union. And what is the problem is the licensing of stem cell research and therapy is so strict all around the world, especially in India, and without bureaucracy. But in NITI University, we were able to procure the license, and we are one of the few centers where umbilical cord stem cell procurement for research and application is taken. And the methodology, as I told you, is this is the SPRP kit. And this has to be standardized, and these kits will have to be procured. And separation of bone marrow from RBCs and plasma by centrifugation. And aspirating bone marrow aspirate ensure 1:5 ratio of acid citrate dextrose into A2BM bone marrow aspirate. And usually collect 20 ml of bone marrow with ACD solution 1:5 volume ratio. And these are procured in different syringes, and depending on how much you want to inject into the fracture site can be done. We also studied the density gradient of bone marrow aspirate in our laboratory. and isolation and expansion of multipotent mesenchymal stem cells from the bone marrow aspirate has been standardized today under in vitro conditions, and performed in vitro characterization of MSCs in terms of their morphology, proliferation rate, and differentiation into capacity into osteocytes and adipocytes. As I told you, the platelets are natural resources of many growth factors which stimulate proliferation of osteoblastic progenitus. And it is very important that these platelets which have these growth factors are taken into consideration. And the concentration of stem cells per ml of BMC varies from 0.0 to 5.4, as I told you, cell surface markers. And that is an important factor which has to be taken into consideration. This is again a picture again to show how the bone marrow aspiration is undertaken, and the collection of the syringes, as you see, the centrifuge with the balancers, and how it is injected into the non-union sites. And the follow-up of every 6 weeks we undertook with the X-ray and 9 months to assess the callus. And the callus score, as by Kim et al. 2009, was followed. Where there is no callus at all, it is 0. Where there is slight callus, it is 1, and the bridging callus 2. So is the posterior, medial, and lateral cortex. And you would appreciate the scoring which is taken into consideration. If the callus score is anything 5 and above, was considered as the fracture united. And these are some of the cases which is an established non-union. And you would appreciate in 8 months' time, the fracture is very well united. And here is the fracture of the humerus, which was done, they're nearly seven months old, and the fracture consolidates after 6 months. This was another fracture of the humerus where you see the non-union, and it would not unite. And after the bone marrow aspiration concentrate injection, the fracture is consolidated and united in 6 months' time. It was a segmental fracture, as you would see, both the segmental level, the fracture had united, and by bone marrow aspiration, you would appreciate the fracture is united. It was actually an open fracture. It was the fracture of the both bones where the radius would not unite, and we had to inject twice into the fractured non-union site, and finally the second after that the fracture united. Here was a 12 months old fracture, 12 months old. Usually we select cases which are 9 months before, but this is after 12 months non-union. After 16 months after this thing, you see the full consolidation of the fracture site, and that is the function. This was one of our failures. What is important is the proper selection. If you select a case where already the ends are completely sclerosed out, the results will be poor. This fracture would not unite. And that is the picture. So bone marrow is a safe and simple option for non-union of long bones. The donor site issue is avoided and could be done repetitively. And as it is performed under local anesthesia, the method evades the risk of general anesthesia, infection, and open surgery. Collectively, this is a simple and effective method of providing cellular reactivation as of today of osteogenesis, and can positively be employed by early intervention. Coming to bone marrow aspiration, AVN, I will take another 5 minutes of this. Osteonecrosis. The causes are varied, as your pathogenesis are poorly understood with the male-female ratio. And I won't go into the controversy of this and the staging of the literature review. We did our study to compare the functional and radiological outcome to and also the complications involved with a core decompression alone or core decompression with bone marrow aspiration concentrate. And these are the guidelines, and this was the selection criteria and exclusion criteria. And the same methodology with patient position in a fracture table and under epidural anesthesia or spinal, C-arm images checked in both AP and lateral views. And that is the picture, that is the site. What is important is to inject the bone marrow. You just curate out the avascular site, as you said, which is usually posterolateral superior, and see that area is injected with the bone marrow aspect. The site of injection is quite important, and how you really effectively curate out is important. we have different types of curettes now, which are angular, so that it can go into any site of this site. And that is how it is curated out. And you put your drill there and see that you make a sleeve to curate out the debris of avascular bone. And again, the BM is prepared, as I told you, for non-uni. And the puffy coat layer is taken. And that is the path which you have made. You see that is the guide wire which is put in to ensure that you are at the site. And that is the way to facilitate better this thing. We have made 2 pathways there so that the whole area of avascular necrosis is reached upon. And that is some of our 18 months post-op bilateral after the MRI follow-up. We took them out. This is the plain X-ray follow-up of that patient. And this is the pathway which you would appreciate. And that is how your drill goes in. And it goes almost up to the subchondral bone. And that is the guide wire which again guides your study. And these are the MRI pictures of preoperative. You would appreciate the avascular necrosis that you will see by the darkness of the posterolateral part of the head. And that is the preoperative, the operative, peroperative X-ray, Chiamen X-ray. And this was a 31-year-old male patient with the avian on one side, which an established both we took, and it was almost 2B, and still we took a chance and did bilateral. And that is the picture which you see after 12 months. And you would appreciate the difference between that and this as you would appreciate in 12 months follow-up. And that is the 12 months only, the core decomposition. This was the 38-year-old, again, 18 months follow-up. You would appreciate the concentric formation of the head of the femur on the left side compared to the preoperative state. Radiologically, there was reduced incidence of progression of collapse in bone marrow aspiration group as compared to the CD group and in all our cases. So this was published in the International Journal of Orthopaedics. So to conclude, bone marrow aspiration concentrate is a safe, efficient, and less technically demanding modality for the treatment of non-traumatic avascular necrosis of femoral head in pre-collapse state. Taking the functional and radiological outcomes into consideration with pain, relief, delayed and reduced progression to collapse. Core decompression with bone marrow aspiration is a better treatment for modality than simple core decompression alone. This is just 2 or 3 slides on our. We are furthering our studies on bone marrow aspiration, cartilage defects, and it is not a controlled study which we have undertaken, but it showed the importance and improved results with bone marrow aspiration in different types of cartilage defects, which is a bigger challenge. And here is a patient you would appreciate the case fairly large on the medial condyle of the femur, and that is the MRI which is shows. And after 6 months, both radiologically and the MRI, which showed that almost the gap is filled up, and the arrow shows that it is almost filled up well compared to the original picture. So, gentlemen, finally, the promise of stem cells tomorrow and today is what is the cultured pluripotent stem cells will have to be taken into consideration, especially for the cartilage transplantation, and the study of cell differentiation is important. So it can be used for bone marrow, for leukemia and chemotherapy, nerve cells in Parkinson's disease, heart muscle for heart disease, and even pancreatic islets for diabetes, especially diabetes type 1. But we should remember that challenges remain the application of stem cells in regenerative medicine, demonstration of cost effectiveness, and evaluation of safety and the risk involved. Obstacles are there. One of the first obstacles that must overcome is the difficulty of identifying the stem cells. That's why I defined stem cells from the adult tissues, which contain numerous mixtures of various cells. The process of identifying and growing the right kind of stem cells, usually is a very rare cell in the adult tissue, involves painstaking research, which is quite important. The second one is the stem cells are identified and the right conditions must be developed to see that they are differentiated into specialized cells. Third, the integration of stem cells into tissues or organs and their mode of action in regeneration or recovery must be very clearly understood before we embark on this. And another challenge is the phenomenon of tissue rejection. Just as in organ transplants, the body's human cells will recognize transplanted cells as foreign, setting off an immune reaction that could cause the transplant to fail and possibly endanger the patient. Whereas the mesenchymal stem cells are non-immunogenic and do not trigger the patient's immune system, which has to be taken into consideration. So the stem cells and regenerative medicine could transform the face of medicine by curing or elevating many of today's most devastating diseases. Stem cell research conducted by developing countries offers the potential to target innovation to local context and make treatment more affordable to the patients. The possible therapeutic application by a somatic cell nuclear transfer technology will be to clone, but it is always a danger. That's why so much of difficulties in licensing, because if it goes to a wrong hand, we can be in great trouble. And that is the cloning which can take place in future if you are not careful. Thank you very much again.
Thank you so much, sir.
Thank you, Professor Shetty. Excellent talk on stem cells and a huge experience as well. I know this is an area which there will continue to be some controversy about, and what is one of the things that is always a bit of a doubt is whether it's possible to do controlled trials on the non-union, especially to see if it is really making a difference or not.
Yeah, that's a very great question. The selection of the cases is very important. So perhaps I did not mention, if it is more than 2 millimeters of gap, especially if it is preferably if it is less than 1 millimeter, that's an ideal situation for this. And the time lag period. If you inject bone marrow aspiration after 9 months, it won't work out. That has been found by all the people who have done this research. And the gap is too much, and already there is sclerosis, and there is no possibility of the osteoblastic proliferation taking place. That's the selection of cases is very important. And even that's why in 2 or 3 cases we undertook with bone marrow aspiration the correction of the deformity at the same time with the Elizaro. So that has to be taken also into consideration.
Yeah. So the big question there will be, if you did matched controls, that means maybe
that's the same type of cases and the same type of this thing, whether with the bone grafting or any other method which you can bring about just with the compression alone, or any other method,
or even maybe pulsed ultrasound, or even just
that's right. Any other non-invasive
over a period of time.
Non-invasive method, all the pulse, all those electrical stimulations have been tried to the agony of the patients in necessary years,
Sure. Yeah.
And we were, especially our generation of people, we used all that, and we all got that machine and used that to the agony of the patient and ourselves, because it wouldn't work out, and finally we had to do a bone grafting. Nothing like a autogenous bone graft for a non-union, and the stability being maintained. But this
Absolutely.
is a new method because this is the non-invasive, and the selection of the cases is
critical to success. Okay, Janki, take over.
Yes. Thank you so much, sir. There are a few questions from the postgraduates.
yes.
One Kumar Gautam has asked is about optimum time of BMA application for non-union case.
No, that's why I told you the 9 months period was taken with all our studies and Kim's studies and different studies around the world. Especially Koreans have done a lot of work on this particular field, and many of the papers which have come through are from Korea, especially from Christian University. So they have optimized the period as 9 months period, but that is optimization. So it can be done. Preferably it is earlier. See, non-union as a definition is no more a fracture that 8 months time or 9 months with the FDA or the AWO defines. If you find that this fracture is unlikely to unite even after 2 months, then it has to be intervened by whatever method you can. Because the non-union is one, that fracture is not likely to unite unless there is an intervention. That is the definition of non-union today. So not the 8 months period or 9 months period of the FDA or the AWO.
So another question they have asked is, does BMA effect in case of non-union vary based upon implant in situ?
Yes, that's it. The 2 or 3 of our patients had implant in situ, but what is important is the unstable implant which is put in can never unite the fracture, whatever. If there is a nail which is toggling, which is not, it has to be changed. If there is a plate where there is movement at the fracture site, it cannot do its job. The stability is important. That's why the selection of the cases is quite important.
So, is any added benefit of BMA and cancellous grafting over only BMA and another type of bone grafting?
No, even today, the best way to treat a non-union perhaps is the autogenous cancellous bone graft with the support. But what is important is the stability of the fracture site itself. At the stability of the fracture, why that fracture has gone into non-union has to be taken into consideration. It can be general causes, it can be local causes. Mostly it is local causes, which has to be answered. Otherwise, it will be a failure. So if you think that what is important in BMAC or even in autogenous cancellous bone or any type of graft which you use, is to see that the stability at the fracture site is maintained. That is important for a non-union to get into a union.
So another question asked is post-operative protocol for avian treated with BMA.
No, post-operative, we do not allow them to weight bear. The toe weight bearing is done after 6 weeks of period. So if it is bilateral, then it becomes a little problematic. So, but many of these bilateral patients, we found that they started, in spite of our telling not to walk, they were to walking or just they had to go to the bathroom. It becomes very difficult. In spite of that, didn't make much of a difference. That was our find.
In few of the papers, I have seen that for the avian with core decompression, they use BMA, and sometimes it is just fibular graft with BMA. So, according to that, what is your experience? What is the
fibular graft we have used before, but it is not. It is a stud graft which really does not bring about greater. What is important is curating out that avascular portion of the. But that is the most important factor in an avian. With the granulation tissue, with the dead tissue there, which cannot vascularize by any chance, or osteogenic potentiality cannot be brought out. So you will have to remove that and then bring about osteogenicity to vascularity to the particular region. That's why above 2B, if you do it, it cannot work many times. It can't.
And so just one added question of that, when we are doing the core decompression, is it that multiple drilling has added benefit over that one?
Multiple drilling, but yes, it is just like curating. What is important is to curate out. That's why we have devised different curates of different angles. Or the latest one that it has come, the same curate can turn into 180 degrees, and this so it has to be made into a vascular area before you really put in the BMAC.
So one question from Avinash is that the PRP, is it same as the stem cell therapy?
No, PRP is a part of stem cell therapy. A lot of papers have come out on PRP in different tendencies and even osteoarthritis of the knees, and a lot of papers have come out. But as I told you, there is a difference between the concentration of stem cells in a BMR, bone marrow aspiration concentrate and PRP completely differs. So it is just a kite flying many times with a PRP that these cells will be stem cells, and there will be some healing process, but we do not know. The final thought is not yet over. So I firmly believe that BMR for a non-union or for an ABN for this thing. But we do not know how even today we do not know how it works in an osteoarthritis of the knee joint. Many papers have come out that they have found good results, but still it is questionable act because the concentration of stem cells, it is not the stem cells which acts purely. It may be the different types of as I told you, the growth factors which may be acting, cytokines which may be acting, but we do not know the correct principles on it, how it works.
So where's the role now for just core decompression in avian, or would you always add stem cells when you're doing it?
Yeah, we have started adding the stem cells in every core decompression.
Every case.
Okay. Yeah, that's right. We used to even we have mixed the cancellous bone which is taken on the drilling point. We push it into that, and then put the stem cells into that, because if it's a large area, so that it will act as combined effect will be there.
And the other thing that is, I don't know, it's directly related to this talk, is that we find some of these avian cases also have quite a significant effusion in the joint, and their pain is often increased because of that. So do you do anything for that while you're doing your aspiration, decompression? And
no, repeat the question again, because
so
it was
some of these patients, we see quite a few of these patients who have pain which has increased, and then you find they have an effusion.
Yeah.
Ultrasound them, you find an effusion, or you do an MRI, you find an effusion. So when you're doing your core decompression and whatever BMAC or whatever stem cell therapy, you also try to do something for the effusion, or you just leave it alone?
No, we didn't, because even the MRI which we have studied, it was one of the theses for one of our boys. Even the MRIs, we did not find much of effusion in these cases. In the initial stages, type 1, yes, type 1, there will be effusion, and they are the right cases to catch them and they really give good results. But we haven't done anything like aspirating.
You don't decompress the joint in those?
No, we haven't decompressed. It's a good thought. We'll have to think about it.
There are a few questions which is asked in the DNB previous year paper about the stem cell. One thing is that discuss the therapeutic potential of a stem cell in musculoskeletal disorders. Although it is covered in the talk, but how to write the answer, that is difficult.
It has to be basically divided into what has been proved till now, and what is being proved, and what is the future. It varies from, as I told you, some of the unconquered areas like muscular dystrophies, unconquered like the spinal cord injuries, which though the Thailand people, they attract some of our patients and they spend 10 lakhs of rupees and come back with bed sores. So that is not, it is not true. So that is the problem with this thing. So to answer that particular question, they will have to go from the osteogenic potentiality of the BMR, the bone marrow aspiration concentrate. Especially in non-union, it is fairly proved now. And the avian, it is fairly proved because many papers have come out throughout the world. Whereas in areas of osteoarthritis, even cartilage defects, it is not very well proved. They have tried extensively the cartilage the implantation and the culturing of the cartilage and put in there. And it is still a lot of papers are coming out. But whereas in muscular dystrophy and spinal cord injuries, it is still not we haven't reached any target. So that should be the type of answer they should give.
Yeah, I think spinal cord injury is such an area where, because of the false hopes that they are to generate, people fall into their trap and then end up spending a huge amount of money and
exactly
showing whether there would be recovery anyway
That's
or not, because anyway you see
because as you rightly said, John, many times the question asked is, how is that you people boast so much that we are doing that, we are doing so much of replacement, doing everything. How is that you say that nothing can be done? When I tell my patient with a spinal cord, with a crushed cord there, we can only rehabilitate and we can fix the fracture. They say, but then why you operate and what happens to this thing? But they don't understand for rehabilitation it is required. So
absolutely, yeah. Because for them the one thing that matters is the muscle power.
Why you say you can't recover? So that is the question they ask.
Yeah, I know that's always an issue.
Yeah.
And what is the status of stem cell, current status about the peripheral nerve injuries?
Status of?
Peripheral nerve injuries, the role of stem cells.
Even that I showed you now this thing also. They are, especially brachial plexus injuries, they are doing a lot of studies on brachial plexus injuries and also on the peripheral now. Peripheral nerve, like the radial now, it depends on, we can easily make out whether it requires a repair or a tendon transfer. Whereas for nerve regeneration, whether it is possible that, especially in brachial plexus, where there is a cord lesion, where it is not a transection, but it is the neural sheath is still there, and it is really there is a dragging injury. I mean, that in such cases they are trying, and initial reports show good result, fairly good results. That has to, the final outcome is yet to be seen, because initially they give a false hope with the papers coming out that this says I have done this controlled study and this one, then it paints off. So it has to be established fact rather than doing it.
There are other questions like describe in brief the current status of knowledge of use of stem cells in orthopedic practice. That the answer what you have given for the previous question, it's same for this one also.
Yes,
the
current concept is the same. Yeah, that's right.
And so one question is about the role of mesenchymal cell in fracture healing, they have asked.
That is MSCs. That's what I told you. The MSCs have a great potential to that. That's why they are the main cells, the mesenchymal stem cells, which are the stem cells with the non-unit. It has to be concentrated with the buffy layer. The mesenchymal stem cells concentrate is much more. That's why the PDG, PGF, and all those growth factors which are important added, and adds to the union of the fracture site. The growth factors and the cytokines are a very important part to be taken into consideration.
And another thing you have covered already, sir, about the avascular necrosis of head of femur, they have asked separately for this stem cell therapy, role of stem cell. Another thing which I just want to ask about the safety when we are using the stem cells, about the immunogenicity or the tumorgenic potential of these stem cells.
That I told you, the mesenchymal stem cells have the least immunogenic properties. So
and you're taking it from the same patient. So
yes, that's right. So that is, especially the mesenchymal stem cells it has been proved now. That's a good thing. Otherwise that was a factor when you taken, as John said, if you take it from some other patient, there is always a problem of immunogenicity.
And sir, so I think most of the things we have covered. The one thing which just I want to know is about the where in India the stem cell centers are.
In India, how far we have progressed. Yeah, different people claim different things, but it has to be established by good research center and lot of, as Dr. John rightly put up, but it has to be standardized studies. We just can't do some studies and publish a paper, and it has to be standardized, and it has to be, even if it is a cartilage transplant, the cartilage transplant has a very big market if you really develop it very well. Even the Western countries have come out with that. You know, so many people are marketing now the cartilage as such, but it is not proved. It has its benefits as it was thought to be. So you will have to really wait and see that, especially that, and even in non-union or even in ABN, the final shape.
I think so. Thank you, Professor Shetty, for
Thank you. Thank you, John. Nice seeing you.
time from your busy schedule to
No, thank you. Thank you.
teach the students, and it's always a
Thank
privilege having
Thank
you.
Thank you so much, sir.
Thank you. God bless. Thank you.
Okay, great. Thank you. Bye.
Thank you. Bye. Bye. John, are you coming to Goa?
I'll just
Yes. He has gone off. John?
yes. I think sir has just left.
Okay, okay. No, I was just asking whether he's coming to Goa. Yeah. Okay.
Oh. Okay, thank you so much, sir.
Okay, thank you.